diagnosis. So I am Ivan Pacheco, pathologist in Owen Sound, and I'm adjunct professor at Western University in London, Ontario. So I would like to thank to Dr. McKee again for his time and his kindness for presenting this series of lectures where he's trying to create a new cemented knowledge of the residents of all over the world and us pathologists and practicing pathologists. So Dr. McKee is going to present today the great mimic malignant melanoma variants, and let's listen from him and thank him again to see what's going to say today for us to us. Thank you.
Okay, well, I'd like to welcome you all. That's the first thing. And I thought I would just start showing you a picture of where I live I live in a tiny little, it's called a hamlet. It's about 200 houses in the middle of the countryside in France. And you can see our house at the back there. That's somewhere between 200 and 300 years old. And there's my wife, Gracie, at the top there with her favorite teddy bear that I gave her many, many years ago. And underneath, we've got the grapevine, which we're hoping to make some really good wine this year. Now, I'm going to talk about melanoma variants, and my talk is really, I think people need to mute their microphones. My talk, as I was saying, it's directed mostly towards residents and fellows. Ivan, is the sound okay now?
Yes, it is now.
Okay. Now, I'm not going to talk about how you diagnose conventional melanoma, because that would take far too long. So I am assuming that you're all capable of diagnosing a regular melanoma. So I showed this slide at the very beginning in the first lecture. And it's really quite nice because in the bottom left-hand corner of this slide, you can see the mutations associated with cutaneous melanoma, mostly BRAF and NRAS, but then there are a whole bunch of other ones. So we have this background knowledge. But I put in this little box here, this is the introduction to the melanocytic chapter in the new WHO textbook on cutaneous neoplasm. And it does intrigue me that they still maintain that the gold standard for melanoma continues to be histopathology. And that's what I wanted to draw your attention to. You know, you can diagnose almost all melanomas on the basis of the H and E. You might like to do all sorts of immunohistochemistry for various reasons, but at the end of the day, a melanoma is a melanoma, and it's not very difficult to recognize that's what it is. There are instances where, for example, you might want to see if BAP1 gene is inactivated, because that might be important if the patient suffered from the inherited BAP1 inactivation gene syndrome. So that would be a very valid reason for using immunohistochemistry. And sometimes with some of the melanoma variants, the tumor cells might not obviously look like melanocytes, and so you might then have to do immunohistochemistry to sort out the histogenesis of the cell type. But usually determining whether it's malignant or not is not going to be an issue. Wait a minute. Right. So I put this slide in just for completeness sake. In 1973, and I was a resident in those days, and Vincent McGovern and his colleagues, who I'm delighted to see included my great friend and hero, Marty Mim, they put together this. This is the sort of the backbone of melanoma classification and subtyping. On the top left, we have lentigo maligna, which is associated with chronic sun exposure. On the top right, we have superficial spreading melanoma, which is more associated with episodes of acute sun damage, particularly if you're young and you get sunstroke a few times. That gives you such an increased risk of superficial spreading. And it's also probably the same etiology for the nodular variants. And a nodular variant, just to remind you, nodular variant implies there is no junctional component beyond 3 Rete ridges on either side. And the implication is that it's so rapidly growing that it quickly outstrips any of the original features. And then the fourth category is the acrolentiginous melanoma, and that also includes mucosal melanoma, and this obviously is not due to sun damage, at least it shouldn't be unless you sunbathe with your feet up in the air. So this is probably not a complete list, but it was a list of all of the variants of melanoma that I can think of. And the importance of variants of melanoma is only that you might mistake it for something else. So it's the differential diagnosis that is the problem. The actual melanoma, it doesn't matter whether it's a nevoid melanoma or a clear cell melanoma or a neuroendocrine melanoma. What it is just a melanoma, and the behavior of that melanoma will be determined mostly by tumor thickness. It's certainly not, the behavior is not influenced by the virtue of the fact that it's a variant of melanoma, with the exception of desmoplastic melanoma, which we'll come to later. And I'm not going to talk about spitzoid melanoma in these talks either, because I covered that when I talked about Spitz nevus. So these are all, with the exception of nevoid melanoma, these are all pretty rare. And some of them you're unlikely ever to see a case of your own, but I will be showing you some. And what I've done with this talk is I put together as many cases as I can of high quality images so that you will see quite a few examples of each one of these subtypes. And so by the end of it all, you should have a jolly good idea of what they actually look like. Now, I'm going to spend a bit of time on nevoid melanoma because it's the one that's going to catch you out. It will catch all of you out. You will all misdiagnose a nevoid melanoma. I have diagnosed a nevoid melanoma. The very first case I saw, which was way back in the early about 1980, 79, 80, I reported a lesion in a lady, and I called it a compound nevus. And about 2 years later, I was sitting in the reporting room, and one of the residents came along and said, "Dr. McKee, can I show you a case?" So I said, "Sure," and I looked at it, and they said, "What do you think it is?" And I said, "Well, it's a nevoid melanoma." And they said, "Well, would you like to see the original report?" And I can tell you my heart sank. I could tell by the expression of glee on the resident's face that it had been misdiagnosed, and I assumed it had been misdiagnosed by me. So I looked at the report, and sure enough, I had misdiagnosed it, and the recurrent tumor was more obviously a melanoma. So I said, "Well, we'll have to sort this out." So we got in contact with the clinician and the patient, and I don't know what happened. I never heard anything more about it, but I do hope the patient did okay. But the important thing is, just so that I make a full confession, that I've misdiagnosed one, and maybe I've misdiagnosed more than one, who knows. The importance of it is that melanocytic pathology is the single commonest cause of medical litigation in pathology in United States and abroad. And you'll see from this publication by Neil Crossan in 2006 that over 50% of physicians will have had a malpractice claim during their career. And I'm very lucky to say that I have not been sued. And I suppose that's just luck rather than anything else. But it's terribly important. And melanocytic lesions are where you will get caught out most often. Now, I just wanted to remind you about mitotic figures in melanocytic lesions. There used to be a tendency when I was training that you saw mitosis, it made you say, "Oh gosh, this has got to be a melanoma because it's got a mitosis." Well, that's not true. You may see mitotic figures in any melanocytic lesion that you can think of, including all of these lesions. Don't forget to mute your microphone. You may see mitoses in compound nevi, congenital nevi, and I went through a lot of these earlier, so it's important. The context is terribly important. When you see a mitotic figure, you need to look around the rest of the tissue and see whether there are other features which might put you in the direction of a melanoma, but a mitosis on its own does not make a melanoma. And this is an example that I showed maybe a month ago. It's just a nice flat compound nevus, and there's the top of it showing type A nevus cells with abundant pink cytoplasm. Somebody's got their microphone on. Please turn it off. And on the right-hand side, you can see the lymphocyte-like type B cells. And at the bottom, there are spindle cells. Those are type C melanocytes. But if we look at the next slide, you can see there's a mitosis right in the middle of the section. And so it would be very easy when you see that, you jump and say, "Oh gosh, this is a melanoma," but it's not. We saw the background of the specimen, and we know it's just a nevus. Whoops, sorry. So, and I showed you this case that Mark Zaki shared with me, again, just to remind you, in pregnancy, you often get large numbers of mitoses. This particular nevus had 5 mitotic figures in one section on H&E, and it doesn't matter, it's still a nevus. So always check whether the patient's pregnant. Now, Wait a minute, sorry, we've gone. So I want to talk about the clinical of nevoid melanoma, and I want to thank Dr. Manu, who's one of our members on Facebook, and Dr. Margboob, who wrote this wonderful paper that I'll be referring to later. But the beauty of the paper is I managed to get a nice screenshot of the clinical and the dermoscopy of a nevoid melanoma. And the important thing really is there's nothing about it that really necessarily tells you it's a melanoma in the first place. Although these authors, when they used their confocal microscopy, did some very clever things, which we'll get to. So nevoid melanoma may present, most commonly it's a warty or verrucous lesion, and less often it has a rather more nodular appearance. And some people in the literature have suggested that those that present with a nodular outline behave in a better fashion. I'm not sure I believe that. It might be true, but I'd be a bit careful about saying that in your report, that's for sure. They may occur at any age and at any site. As I mentioned, there's nothing very distinctive about them clinically. So this is, I think it's very important that we all talk about the same thing, and people use the term nevoid melanoma, to my mind, a little bit too loosely and a little bit too frequently. If, when you look down the microscope, it's obviously a melanoma, well, then it's never going to be a nevoid melanoma, because a nevoid melanoma is a very subtle lesion. It's a lesion that if you don't look at it carefully, you'll call it a nevus. And that's basically all it is. It's a melanoma which you diagnose as a nevus and wish you hadn't. And that, to my mind, is the best definition. And it sometimes, unfortunately, comes to light subsequently, like it happened to me. The patient may come back with metastasis or with a recurrence. And then you go back and look at the original section and you say, oh gosh, I made a bad mistake. And one of the reasons for this is that people, you can get very blasé about melanocytic nevi. And if you have a very heavy workload, in which there are very numerous melanocytic nevi, you can get sort of nevus fatigue, so that eventually you go into an almost automatic phase and you put a slide on and you think, oh, that's a 22-year-old, oh, it's a nevus, and you go on to the next case. And that's the danger. You need to spend a couple of minutes on each and every nevus if you want to make sure that you don't miss a nevoid melanoma. And I'm going to emphasize this again. If you think you haven't misdiagnosed a nevoid melanoma, well, you just got to wait for a bit longer and it'll come to light, I promise you. So a nevoid melanoma, I rather like this image. You could regard it as a wolf in sheep's clothing. Now, what have oh no, I must have gone, there we are. So I mentioned clinically they may be verrucous or dome-shaped, and so histologically they're verrucous or dome-shaped. One of the things about nevoid melanoma, particularly the verrucous variant, is they often develop in elderly patients, and the scalp seems to be a particular location for that. So if you have an elderly patient that presents with a a warty or verrucous nevus on the scalp, be very careful that you don't miss verrucous melanoma, because it's a real pitfall. Now, sometimes they have recognizable junctional activity, but very often there's not an awful lot. You don't get nevoid melanoma arising in a background of one of the precursors that I mentioned earlier. It's a sort of a de novo lesion. Sometimes it's completely dermal, so if you like, it presents as a dermal melanoma. And the easiest way to recognize it, I hope you can see this. I'm using the pointer to highlight these expansile nodules in the papillary dermis. They're all over the place. When you see expansile nodules with compression of the connective,
Mute the microphone.
when you see compression of the connective tissue, please turn off your microphone. When you see compression of the connective tissue between the expansile nodules, that is never, ever, ever going to be a nevus. It is a melanoma. As a result of this, you often get compression of the rete ridges, and they give you this fenestrated or retiform net-like appearance. But you got to be careful, because you can see that in a benign nevus too. So when you look at nevoid melanoma with higher magnification, it's a sort of a definitional thing. I restrict its use to those lesions which mimic type A nevus cells. So they are cells with fairly abundant, they can be amphiphilic cytoplasm or eosinophilic cytoplasm. And they show subtle pleomorphism. The nuclei are mildly pleomorphic. They may show a hint of nucleolar prominence. And most importantly, they don't mature with depth. And I'll be emphasizing that as we go along. I'm going to show you a whole lot of cases. And they show mitotic figures, including the deep aspect. And you make the diagnosis by looking at the big picture. The low power gives you this impression of nodularity. You get the impression that maturation is not quite right. And then you look with high power and you see these features and you pick up mitoses. And I put this in just for those of you who have a molecular turn of mind. A small number of cases have been shown with NRAS and BRAF mutations, but there's not been a lot of molecular studies on nevoid melanoma that I was able to find. Now, Antonina Kalmakova and I we were in the preparation of spending 2 days. We were presenting material at a workshop in Florence in Italy, and then COVID came along and that was the end of that. But in preparation for that, we gathered together a large collection of nevoid melanomas, and I'm going to show them to you. And I just want to emphasize that the majority of these were shared with me by Antonina. So here's the first case, and this is the low power view. And there are two things that I think you can recognize at this magnification. First of all, you can see there's some junctional activity. So we know that it's a compound lesion. And then secondly, even at this magnification, one can tell that there is no maturation at all. The cells at the top, the cells in the middle, the cells at the bottom are exactly the same size. So you could look at this, and I think you can be quite confident with, even if you didn't have any other objectives, that has got to be a melanoma because of that lack of maturation. And there's, just to show you the top of the lesion with the junctional activity, it's best seen here if we regard this as the superficial area, so that you get in your mind's eye what these cells look like. They're quite large, they've got abundant cytoplasm. They're not really forming nodules, they're just forming sheets of cells in this example. And then there is the lower part of the lesion, there's the top, there's the lower part. So the lower part and the top look just the same. And there's the bottom. And you can see there is absolutely no difference between the cells at the top and the cells at the bottom. However, they do not show typical melanoma morphology. That they don't show you the pleomorphism, the huge nuclei, and so on that you would expect to see in any old regular melanoma. They look nevic, and that's why this lesion is called nevoid melanoma, because it looks like a nevus. But when we looked at it carefully, this is taken at very high magnification. There is one, there are two, there's a third, there's 3 mitoses in that one high power field, and there's another high power field. That's the epidermis at the top. There's the 4th mitosis, there is the 5th mitosis, and just to finish off, there is a 6th mitosis. So that lesion had 6 mitoses. And when you add that together with the morphology and the lack of maturation, one does not have any hesitation in calling that nevoid melanoma. And the thing to remember is the diagnosis is on the H&E. You do not need to do any immunohistochemistry whatsoever on that case. There is no point in doing HMB45, P16, Ki67, cyclin D1, and all of the rest of it, because you diagnose it on the H&E. And I'm going to make that point regularly to you, because one of the things I notice on McKee derm is that people jump to immunohistochemistry. In fact, some people will say melanocytic lesion, I would ask for, and then they list all these antibodies. But if they'd looked at the case with the H&E, they wouldn't have needed the antibodies. The diagnosis was staring them straight in the face. So here's another one from Antonina. This is a little bit more difficult, I think, because you can see that it's quite a deep lesion, although a lot of this is still papillary dermis. You can sort of, this is proper. There's the superficial vascular plexus there on the right-hand side, and there it is on the left-hand side. So most of this tumor is in an expanded papillary dermis, although at the very bottom, I think it is trickling into the reticular dermis. But at this magnification, you get the impression that there's the nest size is getting smaller with depth. And so you think, oh, I think that's showing a bit of maturation, but you'll see that that's actually not true. It's pseudo maturation, and I'll show you that in a moment. So here we are. There is the top left is a slightly higher power view. On the top right, you can see the epidermis just at the edge there. So this is the most superficial part of the lesion. On the bottom left is the middle of the lesion. On the right-hand side, this is the bottom of the lesion, and you can see that the nuclei at the bottom are no different from those at the top. And so this apparent maturation is in fact not maturation in the sense that the tumor cells are no different. And so we can say there is impaired maturation with depth. And here, here are some mitoses. There's a mitosis in the middle of the top left. There's the epidermis. Somebody needs to mute their microphone again. There's somewhere around the middle with a mitosis in the middle of it there. I've forgotten why I put these in. I think they're just to show some nuclear pleomorphism. I don't think there are any mitoses in those fields. So that was another nevoid melanoma. Now, the very first case I showed you had two pieces of tissue, and this is the other piece of tissue, and I've got these cases modeled around. This actually should have come next, but it just shows you exactly the same thing. You can tell that that it's compound. Again, you can look very easily and see there's no maturation with depth. And there's a higher power view. It's very obvious. Now, anybody who doesn't recognize this as melanoma right now needs to go back to the drawing book and start all over again. I mean, look at that. Isn't that just, this is such a beautiful field. You know, it's child's play. That cannot be anything but melanoma. It's impossible. There's a mitosis. I put one up there at the top, and there's a high power field showing subtle pleomorphism, and some cells, the nuclei are a little bit too prominent. And there's another mitosis in the middle of the lesion there. And this is, I love this case. This is my favorite nevoid melanoma of all time. This is from an elderly patient, and it's from the scalp. And when you look at it, it's warty. And I mentioned earlier on, warty lesions on the scalp, be very careful. And I suppose one of the features that disturbs me about it is the bottom of the lesion has got, it isn't infiltrating and becoming single cells as you'd expect to see in the dermal component of a compound nevus. There's a sort of a flat lower border, which I think is a sort of a clue that all is not well. There's a very heavily pigmented bit over here, which is a bit disturbing as well. It catches your eye. And there is some expansile nodularity in the papillary dermis with stretching of the rete ridges. So there's enough at low power to make you a bit concerned. And there we see it at slightly higher magnification, and you can see that there are expansile nests, best seen on the far left here, where right in the middle, but in this great space between two rete ridges, you can see a nice expansile nest. And I think you can also tell, if you look at the morphology of the cells in the top of the lesion, and then we go down to the bottom of the lesion, I think one gets an impression that there's no maturation. And here we have, you see, there's the top up there, and there's the bottom down there. And it's very clear that these cells here are no different from those cells at the top. There is impaired maturation. There's the top of the lesion there. There's a lot of junction activity, which on its own is a bit suspicious. You know, nevi tend to develop in adolescence and in the younger age groups. When you've got to about 30 or so, you really ought to have all of the acquired nevi that you're going to get. Now, there are some publications which show that you may get nevi at any age in your life, and I'm sure that must be true, but at the same time, I think a newly acquired nevus in a 70 or 80-year-old, that's always going to worry me. And there's the bottom of the lesion, and you can see there's no maturation whatsoever. Now, this was quite a thick section, and I could not photograph any mitotic figures in that one, so I can't show you mitotic activity, but I was able to see a couple, but they were cut at such a funny angle that the photographs weren't worth showing you. But take it from me, that sort of lesion, if you hunt, you'll find mitoses. And then this is one that Eduardo Colongi shared with me, and it's a lovely case. And again, it's quite difficult because when you look at it low power, I can't remember the clinical information for this patient, but you do get the impression there's some maturation. On this bottom left, you can see some rather worrying cells in the epidermis. They're not forming nests, but they're certainly not very good looking cells. And then if we compare the left side here with the bottom right is the base of the lesion, and you can see there's absolutely no maturation. And then we have another look. There is the top of the lesion, and you can see there's obvious pleomorphism, which wasn't really evident so much on the low power, but on the higher power, it's a bit easier. And there's a mitosis there, and there's another one there. And that's in the middle of the lesion. There's another mitosis, and there's another field. Again, it's showing it's not wild pleomorphism, but I suppose with higher power magnification, you might just want to call this a melanoma, but it sort of overlaps with nevoid. And then I wanted to show you this case. This is not a nevoid melanoma, but it's so beautiful, I had to show it to you. This is a melanoma arising in a nevus. Now, David Elder, I think he made the comment somewhere around that he thought that 30% of melanomas arise in a nevus. Now, I'm not sure whether he meant just dysplastic nevus or whether he meant all nevi. My experience, that's not so frequent, but it may well be that we're looking at different populations. When I was working in Boston, we got so many nevi from young people, and they vastly overwhelmed the number of melanomas we saw. So perhaps that gives us a bit of a bias. I wouldn't have thought that I would have seen a nevus in a pre-existent, I wouldn't have seen a melanoma in a pre-existent nevus in more than maybe 5% of cases. But anyway, this is one such example, and it's absolutely gorgeous. Most of this is melanoma, sort of 60% is melanoma, but the small blue cells that you see in aggregates dotted throughout, that's the pre-existent nevus. And on the top right, this is more obvious. You can see the aggregates of nevus cells, and the bottom two images are of the melanoma, and we'll look at that more closely in a moment. Isn't that gorgeous? You see, there's obvious pagetoid spread in the top left, so we know this is melanoma. And here we see the nevus. It really is so pretty. Those are the type B nevus cells in the bottom right. And now I was making the point earlier on about why you don't need immunohistochemistry, but sometimes you need it so that you can just show some pretty pictures. And I persuaded Antonina to do this for me. It was very expensive, and I think she lost most of her salary for the month to pay for all this immunohistochemistry. But there you are, HMB45 staining the melanoma and not the nevus, Ki67 in the melanoma, not in the nevus, and cyclin D1 in the melanoma, not in the nevus. So the immunohistochemistry was very pretty, and it did what we wanted it to. If it hadn't, I wouldn't have shown you the images, obviously. Now, more cases from Antonina. Now, it's a semantic issue, this really. I like to subdivide melanomas. I'm a splitter when it comes to melanoma. Appendage tumors, I tend to lump things together because it's convenient and there are too many subtypes. With melanoma, I tend to split things. And if the melanoma cells look like type B nevus cells, in other words, they look like lymphocytes, then I call it a small cell melanoma. But the WHO, and to her credit, Antonina herself, she regarded this as a nevoid melanoma, and she's probably right. I'm just using it for my convenience because I wanted it to be a small cell melanoma because the nuclei are very hyperchromatic. You can see junctional activity. There's the top and there's the bottom, and so it's obviously a melanoma. But here's another one that Eduardo Colongi shared with me. This is quite a difficult case because I don't really know what's going on here. There's a huge infiltrate extending from the top of there's a Grent zone, as you see there, and then there's this tumor going all the way down. It goes down into the reticulodermis. You can tell it's reticulodermis because you've got these great bundles of collagen, and the cells there look like lymphocytes. They look like type B nevus cells, but the thing was teeming with mitotic figures and the significant nuclear pleomorphism. I haven't got any photographs of the well, I think there's a mitotic figure there, a rather degenerate one. So that again, that's an example of small cell melanoma. But to my mind, it rather than looking like a nevus, I thought it looked more like a congenital nevus, and if you weren't careful and you went too quickly over that, you might end up calling it a congenital nevus, and that would be a terrible mistake to make. Now, I have to show you this because I want you to know that I am up to date in all techniques scientific, and this is a wonderful paper. Doctors Manu and Mark Boob presented in the JAD 2017, and this was presented at the 2019 McKee Derm conference, which Antonina Kalmakova and CSD Healthcare organized in Kyiv. And I thought this is such a cool technique. Now, I can't pretend, I'm not going to pretend that I could interpret this myself. It is far too sophisticated. But suffice it to say that what you can tell is in this insert, at the top right-hand corner, you can see little red arrows. And those red arrows are pointing to nests, expansile nests in the papillary dermis. And that is a wonderful display of non-invasive microscopic diagnosis. So these ladies were able to diagnose a melanoma on the basis of clinical dermoscopy and reflectance confocal microscopy. Now, that is quite worrying, because it's beginning to say to us that we are going to be out of a job. But I'm going to reassure you, the one thing that these guys have not yet managed to sort out necessarily is tumor thickness if it's a thick melanoma. Sadly, they can measure tumor thickness with confocal microscopy if it's a tumor that's in the papillary dermis, so they could render us redundant. But if it was a big melanoma, then the laser beam doesn't extend deep enough. But it's so clever. So now there you are. If you didn't know this, I've hopefully educated you with it. Now, there we go. And I love this web blog, Singularity. I'm very into singularities. They're one of my interests in life these days. And there is the Grim Reaper. And the point of nevoid melanoma is the prognosis of nevoid melanoma is no different from any other melanoma. Same recurrence rate, same metastasis rate, same death rate. And the importance of nevoid melanoma is you just report it as you would for any other melanoma. And I put this, this is a paper that was in JCute Path, in which they did fish on a series of 58 cases of nevoid melanoma, and they showed that copy number gains in 8q24 were common in nevoid melanoma. So that might be useful if you have a difficult case and you want to get something to make you feel more comfortable. So fish, I think, maybe will become more used. Now, I'm turning next to nested melanoma. And it's called nested melanoma in the elderly, and some people have called it atypical nevus of the elderly, but it's all the same thing. And it's a bit of a misnomer, because you don't have to be elderly to get one. And this is a case report here of a 52-year-old man. Now, I'm 72 and I regard myself as still quite young. So 52 makes you like a baby in the mother's arms rather than an old person. And all it is it's an in situ melanoma, which gives you these very large expansile nests, which typically bridge. So the bridging makes you think of a dysplastic nevus, but it doesn't have the architecture of a dysplastic nevus, and it doesn't have the stromal changes of a dysplastic nevus, and they tend to develop on the chest. Now, they are mostly middle-aged and elderly, but they're not totally middle-aged and elderly. And there's a close-up view of that particular lesion, and you can see that the nuclei are very prominent, and the nuclei are pleomorphic. So that tells you that you're looking, and all of the cells are similarly affected. And so the reason I call this a melanoma, a nested melanoma rather than a nevus, is because the degree of cytological atypia is throughout the lesion. If it was only scattered cells, then I might call it an atypical nevus. But because they're all affected, I would call it an in situ melanoma. And look at this, isn't this a gorgeous case? This one's invasive. You can see the tumor there in the papillary dermis. And but if you look on the right hand side, you can see the junction activity. There's also some pagetoid spread going on. So that's a clear melanoma. I don't think it's of any great importance other than if it's in situ, you might mistake it for a dysplastic nevus, which would not be a good thing to do. If it's invasive, well, then I don't think it's going to behave any different than any other melanoma. Now, lastly, I want to talk about desmoplastic melanoma, and that's the other very important subtype because it behaves a bit differently from the more usual melanoma in that it tends not to involve the lymph nodes. And when sentinel lymph node biopsy was in its heyday, we used to say, don't bother doing a sentinel node biopsy in a desmoplastic melanoma because it won't tell you anything. And they're rare tumors, although we seem to see a lot of them on McKee derm, and so people will have seen lots and lots of them. But in your daily practice, if you're working on your own, you probably won't see more than one or two of them in a year, I wouldn't think. And they occur as a consequence of high cumulative sun damage. So they often arise in a background of lentigo maligna. But sometimes they don't, and they appear to arise de novo as a dermal tumor. And not surprisingly, they arise most often on the head and neck. You can get them on the backs of the upper limbs due to sun exposure, or in the V part of the upper trunk. And they can be very deceptive clinically. When they're not pigmented, they can look like any old sort of a thing. Sometimes, as I'll show you, they look a bit like a keloid. And I remember that I started my pathology in 1972, and I remember this paper by Conley. It was a great paper, and in fact, if you go back and read it, it's as good as it gets, really, other than giving you, the molecular stuff which we know now. But other than that, and this is a very good paper I wanted to recommend to you by Manfredini et al. In Future Oncology, and I found this in PubMed, and these are all clinical pictures of desmoplastic melanoma. And they're absolutely, this one's really very destructive. And I want to make that point to you that desmoplastic melanoma very, very commonly extends down nerves. Now, I mentioned this a while back, and I said that if you got a desmoplastic melanoma, it invariably spread down nerves. Now, Artur Zembovich, who's a very, very good friend of mine, he disagreed with that and said that that wasn't necessarily true. So I stand corrected. But I would say that if you get a desmoplastic melanoma, it's desperately important that you look for perineural infiltration, because sometimes these tumors grow deeply down nerves and they can follow a cranial nerve all the way back to to the base of the skull and affect the meninges. That they can be dreadful tumors. Now, histologically, I like to say, and here's my rule of thumb: when I start looking at a cases in a sign out, I have certain things that I say to myself every time. And the first thing I always say to myself is, do not forget about desmoplastic melanoma. Have it somewhere near the surface of your memory so that if one pops up, you don't miss it. And the low power clue to a desmoplastic melanoma is the presence of lymphocytic infiltrates. So if you see a skin, this one's obvious. There's obviously something horrible going on in the dermis. So you can make out that there's something, you know, that, I mean, you can tell there's a melanoma here, but they can be much more subtle. And these lymphoid aggregates are telling you, they say, please look at me carefully because I am giving you advice. So that's why that's got a star. They are variably cellular. Sometimes they're so acellular that you can barely see them. And now I don't know the answer, but I do believe we have a case that's posted at the moment on McKee that I suspect is a desmoplastic melanoma. And if I'm right, it's very paucicellular. And sometimes the cells can have a rather myxoid spindle cell appearance, or they can be densely collagenous. Nuclei tend to be hyperchromatic. Pleomorphism is variable. What I would say is, in my experience, they're always spindle cell. I don't think I've ever diagnosed an epithelioid desmoplastic melanoma, and that I suppose is because desmoplastic melanoma arises in skin with high cumulative sun damage, and that gives you spindle cells. So that's my rationale. I mentioned neurotropism. I also wanted to highlight sometimes you can get neural transformation, and so I remember one case which sadly I've lost, where the desmoplastic melanoma turned into a thing that looked like a rather pleomorphic traumatic neuroma. It was an amazing case. And then I want to mention this variant where you get a mixture of desmoplastic and spindle cell melanoma, and that may account to up to 50% of cases. If there are clearly recognized spindle cell bits of the tumor, then you do not classify it as desmoplastic melanoma. You just call it a melanoma. So this is a pretty typical desmoplastic melanoma. This is the one that I was showing you at low power, and you can see aggregates of spindle cells, but there's a lot of sclerotic stroma, lots and lots of collagen. as you see there. And this is another view. This is towards the base of the lesion where you've got single cells coming down and beginning to infiltrate subcutaneous fat. So here is, this is another one. And I've forgotten, I can't remember any clinical information on this one, but we'll look at it at higher power. And here you can see the surface where there's nothing, there's not a lot going on there. You'd be hard pushed to say that this tumor was arising from the epidermis. Maybe deeper levels or a different block might have done, but I wouldn't be too inspired by this. But here you can say it almost looks neurofibroma-like. There's a lot of cytoplasm and these small spindly cells, not desperately pleomorphic either. In another part of the tumor, you can see it's more obviously spindle-celled. So this, in fact, may turn out to be one of those mixed tumors I was mentioning. There's the base of the lesion, where again it's very desmoplastic in that field. And there's a mitosis. You don't often, well, you can see mitosis, but they don't tend to be desperately prominent. And there's lovely neurotropism. There's a nerve fiber there, and this is all tumor growing along the nerve. Somebody's microphone needs muted. And then you see Antonina, she's such a kind person. She's shared all of these cases. So I'm going to show you a whole bunch of cases from CSD healthcare. If it wasn't for CSD healthcare, I would have precious little to show, to be honest with you. There you can see really, really bad cumulative sun damage with massive solar elastosis. And there's a pigmented thing at the top. And when we look at that at closer, it's obviously a heavily pigmented melanocytic lesion. It looks as if it's, I think I can just about make out some dermal component there, but I think if we look at higher power, we'll see that better. There's the in situ component there. Did I take it? No, I think I didn't take any more photographs. Anyway, this was not obviously. I don't think I was able to tell with confidence whether there was or was not a dermal component, but there might be. But it's certainly at least lentigo maligna. But then it recurred sometime later, and you can see this nodule of recurrent tumor. And this is one of these mixed tumors I was talking about, with desmoplastic forming part of it. It was Klaus Buesheim. I've been trying desperately to remember who wrote that paper. It was Klaus Buesheim who wrote the paper on mixed spindle cell and desmoplastic melanoma. And this bit's more spindle cell-y there. So there's the top. There's some sort of actinically damaged melanocytes, but it's not really obviously a melanoma at the top, but there's fantastic elastosis. There's a medium power view. There are lymphoid aggregates, and they're always telling you something, as I've mentioned. This bit here is more obviously a spindle cell melanoma. And there's a close-up view there and there. And here it's a bit more desmoplastic with a rather myxoid spindle cell infiltrate. So that's a lovely example of a mixed tumor. And there's more of the of the desmoplastic. And that's SOX10. I'm not sure why Antonina did SOX10, but she did, so I took a picture of it. She can maybe tell us afterwards why she did SOX10. And here's another one. And I just wanted, I'm not going to talk about bullous melanoma because it's not really that interesting. But if you look carefully where the arrow is, you can see there's a blister. There's a subepidermal blister on top of the melanoma. The other thing I'll draw your attention are these lymphoid aggregates, which are telling you this is not good news. And then the next picture, there you can see obvious in situ melanoma, and deep to the in situ melanoma, you can see a desmoplastic component. It's not desperately pleomorphic. The cells have hyperchromatic nuclei, and there's an almost rather mixoidy look to the stroma. Oh, I forgot. Yes, I meant to show you that. That was just, again, whoops, sorry. I wanted to highlight the blister on the right, but we won't spend too much time on it. There is the deep part of the lesion, and you can see it's a rather paucicellular lesion. And those are just more images. And this last one I wanted to show you. It's a case that I got years and years and years ago, and I apologize for the horrible color, but I was spending too long trying to fix it, so I gave up. And again, you've got this bullous component at the top, just to draw your attention to that. And there is clear in situ melanoma. There's gross solar elastosis, but the dermal bit looked a bit more like a neurofibroma, except there are very ugly nuclei. And I thought this would be a nice example if you wanted of so-called neurotization, but that might be stretching things. And those of you who are molecular pathologists, I had to put this in because this is jolly interesting. Rather than seeing the BRAF mutations that you see so often in other melanomas, in desmoplastic, you don't see that. You get different mutations, particularly in NF1, which accounts for 55%. And other common mutations are the P16 mutation and P53 mutations. So desmoplastic melanoma is a sort of a separate entity in terms of its biology. Now, immunohistochemistry, you all know that MART1 HMB45 don't work. I put this in because I think it's quite useful when you're trying to find nerve involvement. It can be quite difficult. And when I was in practice, I used to use CD57, which highlights the nerve fibers. And there's a lovely nerve you see with the nerve fibers shining up with the peroxidase, but there's clearly tumor around them. So it's a good way of picking up neurotropism. And then lastly, my good friend John Ho from University of Pittsburgh and Kiko.com, he allowed me to show this case. This is really a neurotropic melanoma, and it's rather interesting. Hang on, I didn't want you to see that just yet. Whoops, I've gone the wrong way. Anyway, it was interesting because the top of the lesion looks almost spitzoid or superficial spreading. It's not really a very typical lentigo maligna appearance, that's for sure. But that was just an incidental finding. So it's a spindle cell melanoma, but there's every nerve and site's involved. And on the bottom right-hand corner, you can see one nerve there, but the next image is just fantastic. There's the low power view. You see, there's a huge nerve there, On the right hand, you can see it in close-up, absolutely stuffed full of tumor. And there are more, there's 1, 2, 3, 4 cuts of nerve showing neurotropism. And there's another field with neurotropism. So, and you can see how deep that is. So you can imagine how difficult that's going to be to excise, and you're going to have to work very hard to get that completely excised. So that's all I have to say on desmoplastic melanoma. And I'm finishing up. I think this is probably one of the most beautiful photographs I have ever seen. And my daughter Andrea took this of a wasp, of a bee rather, getting itself ready to suck some honey out of this flower. So that's the end of the talk. So I'm very happy now to finish up, and I'll minimize this, and answer. We can start. I'll answer any questions you like, provided you you keep it to the topics that I've discussed. I don't want to be talking about variants of melanoma that I haven't yet got to. So questions really about nevoid, nested, and desmoplastic melanoma. Okay? So shall we go back to, shall we stop?
You can still leave the sharing. Everybody can unmute themselves now and ask questions.
If I close the presentation,
will just be the video feed from everybody then.
Okay, so save. So now that's gone. Now,
no, I have a couple of questions from Facebook here. I think you tangentially you took a subject here. Hello.
So yeah,
you were speaking about the nevus in pregnancy.
Yes. Now, hang on. I'm just getting some nicotine to keep me going. Yes, nevus in pregnancy. Yes.
So does cycling? Leila Ahmed is asking, does cycling D1 help to differentiate between melanoma and nevus in pregnancy?
I haven't the faintest idea. Okay. I've never done cyclin D1 in nevus of pregnancy. You see, it's the wrong way around of looking at things. Now, can a pregnant woman get a melanoma? Yes, she can. Can you recognize a melanoma in a pregnant woman? Yes, because it'll look like any other melanoma. It just looks like a melanoma. Could a pregnant woman get a nevoid melanoma in pregnancy? I'm sure that's possible, and I think I saw one once in Boston, and I called it nevoid melanoma, and it caused a bit of a kerfuffle because some other folk wanted to call it nevus of pregnancy. And we never really resolved who was right on it. But I do remember it had 6 mitoses, which I thought was a bit much for one high-power view. However, the point is, a nevus of pregnancy should show maturation. It shouldn't show significant pleomorphism. What you see is it may be increased pigmentation. You may see quite a few normal mitoses, and sometimes you get these little expansile pseudonodules right up in the papillary dermis. And importantly, you use the best special stain to use for nevus of pregnancy is the telephone. And you phone up the doctor and say, is she pregnant? And if he says, yes, she is, well, then you know where you are. If he says, no, she isn't pregnant, she's actually 78 years old, and it's not a miracle pregnancy, then you know you're in trouble and your diagnosis is wrong.
Now, I have another question from Facebook, Mariama Joseph. She's a dermatopathologist at London Health Sciences in University of Western Ontario. In a
Lovely to meet
superficial
you.
In a superficial biopsy of a desmoplastic melanoma that looks like neurofibroma, which immunomarkers are most helpful? And if you use them, or what features, I guess, histologic features you will use?
If it's a superficial biopsy and you're worrying about whether it's a desmoplastic melanoma or a neurofibroma, gosh, that's quite difficult. One of the things you could do would be CD 56 or 57 that I mentioned, which highlights nerve fibers. That would be one thing that you could do. The conventional immunomarkers wouldn't necessarily be much use to you. If the lesion, I think you would go a lot by nuclear morphology and also by clinical information. If the lesion was from the sun-damaged skin of an elderly patient and it was a shave biopsy with some scattered spindle cells, it might be very, very difficult, is the honest truth. One of the things I've discovered over the years is one has to be very cautious in interpreting spindle lesions in shave biopsies because I've been caught out a number of times. I remember one in particular that I'm sort of digressing, but it's just interesting. I had this spindle cell lesion that was a shave biopsy and it looked as if it might be an AFX. So I suggested the possibility of an AFX. And Chris Fletcher phoned me up a couple of days later and he said, did you know that that shave biopsy, the actual tumor was 10 centimeters in diameter and it was coming from the underlying muscle and it was actually a leiomyosarcoma. So you learn. So yes, I think it could be very difficult, but I think the nuclear morphology would probably be the most useful thing in a shave biopsy. You would pick up hyperchromatism and a little bit of pleomorphism. Mind you, you then would have the problem is, could this be the superficial part of a malignant peripheral nerve sheath tumor, I suppose? And that would be very difficult.
Okay, now I think the floor is open now for the Zoom audience. Maybe Dr. Antonina, she can
Dr.
comment.
Antonina, would you like to say something? First of all, you could say hello.
Philip, hi.
Hi,
Do you
Antonina.
hear me?
I can hear you I can even see you. You're looking jolly
Oh,
well.
hi. Thank you so much for lecture. And I have to say that you collect all interesting cases that we have in our pocket. So we have to find more, I suppose.
I think so.
Yeah, thank you so much. And just my question was about neurofibroma and desmoplastic melanoma. Someone already asked it.
Well, what immunohistochemistry would you use?
Actually, it's a big problem. We don't have CD57 in our lab, and it's kind of hard to stain it. And there is no useful immunohistochemistry. Actually, I more rely on lymphocytic aggregates and age of the patient. I searching carefully for junctional component, and it's also quite useful. But sometimes I ask some help sometime in Machiderm. It's true.
I wonder, does anybody else use CD57 or is it just me? Any comments?
Have it. We don't use it in any other purposes.
Now,
I used to use it and I thought it was great, but maybe it doesn't, people have moved on. Are there any other specific nerve axon markers that you can use that anybody knows of? Because I don't practice dermatopathology anymore. I'm retired. Any thoughts, anyone? Must be a neuropathologist somewhere in there.
I will ask our neuropathologist.
If you ask and find out, and then we can post it on McKee Derm, and then everyone will know.
Now,
And if you don't belong to McKee Derm, you ought to join.
now
Any other questions?
the question I have actually for Antonina is her experience with Soxten, because when I use Soxten in our lab, it's really difficult to determine the depth of invasion sometimes. So that's what we use, Soxten. But then you may have some neural set that they're still marking for S100 or Soxten. So then how do you actually use Soxten in your practice?
Actually, in those cases that Philip shows, I use Soxten just to highlight the depth of the lesion, and that's all. In differential, it doesn't matter, and it doesn't help much, but in desmoplastic melanoma, I use it to highlight the Breslow. And sometimes I use it to highlight the melanocytic origin of the tumor. That's all.
Yeah.
No,
I just used to use S100, to be honest with you, because it's not that difficult to tell whether something's a nerve or not, is the honest truth. I mean, you know, if you look at the H&E and look at the S100, you can see where the nerve is, and so you know, you obviously don't count the nerve, but S100 is. People do talk about S100 negative desmoplastic melanomas. I know Chris Fletcher talks about them, but for practical purposes, they are. I still think it's probably the best marker for general use.
Now, there is one more question here from Facebook, and I think it's quite interesting. How can we differentiate between Nevoid melanoma and melanoma rising on pre-existing benign dermal nevus? I think you show one case like that.
Yeah, I showed you a case of that. No, it's a fair question. I have to be honest. Nevoid melanoma is not really a variant that arises. In my experience, I have not encountered nevoid melanoma arising in a pre-existing nevus. I have seen them, they either arise with some atypical junctional activity with perhaps in situ melanoma, or else they present in the dermis and the whole thing is melanoma. I think I've never seen a nevoid melanoma in a compound nevus or in a congenital nevus. You do see melanoma, standard melanomas, obviously. Where I'll tell you where I'm just thinking out loud. I'll tell you where you might come unstuck, and that would be a BAP1 inactivated tumor arising in a nevus is quite common. So when you look at BAPoma and one of the features, I don't know, 60–70% of them have an adjacent banal nevus. And if that BAP1 inactivated tumor was a melanoma and you weren't looking at it properly, you might confuse it. That could be a source of confusion, because BAPomas can sometimes look more nevoid and they don't have such obvious eosinophilic cytoplasm with inclusions. They can be rather deceptive. So that would be a circumstance. So I tell you what, then, if that was crossing your mind, you could do a look for BAP1 expression and see whether it was whether you had two different populations. And if you had loss of BAP1 expression in a great chunk of the lesion, then you would know that you'd know the starting point, and then you could look at that half much more carefully. And if you found lots of mitoses, then you might be looking at a melanoma rather than just a BAP1 inactivated nevus.
Now, Dr. Karima Sidhom from Egypt, she's actually commenting HMB45 will stain the dermal melanoma cells, but not the nevus cells. That's actually something that we can actually see when you have a melanoma rising from a nevus, right? I've seen it in our practice as well. So that's
yes. You certainly can, but we're talking about in the context of nevoid melanoma, you see. And the point I was making was that I've never seen a nevoid melanoma arising within a nevus. If you talked about melanoma arising in a nevus, any old melanoma, sure, if you do HMB45, it'll stain the melanoma and not the nevus. But I don't know where that's not really the same context as we were discussing earlier. But Karima, thank you for the question, and I'm glad to see you're up and with us.
So Dr. Kim Hyatt is saying hi. She's in an
Hi,
airport
Kim.
right now, and she's saying that she will use CD57 for, as you mentioned before, a suggestion. So now, anybody has more questions or comments?
Okay, well, I think we've done pretty well, and probably now's the time to get out while the going's good before people get bored. So thank you everybody for your attention. Now don't forget, we're going to post this as a video later after Ivan has done all of the clever things he does. And it's very important to remember, if you think of questions or if you disagree with something that I've said, please post that when you see the video, because I love the interaction with you, and you know, I too have feet of clay, so sometimes if I get something wrong, you can tell me, and then I can learn from you guys. It's a two-way process, isn't it?
Definitely.
So thank you everybody, and bye-bye, and we're going to meet again on the 25th of this month, and we're going to start that session with some wonderful cases of melanoma with heterologous differentiation, which are great. They're great fun. So have a good 2 weeks. Look after yourselves. Stay away from COVID. Don't forget to wear your masks even when you go to bed. Even when you're in the shower, keep your mask on and sterilize your entire body, every part of your body, leave and be good. Thank you very much. Bye-bye.